Hello everyone, we are now going to go over the peripheral blood flow cytometry plots from a 5-year-old boy who presented with anemia, thrombocytopenia, and leukocytosis. So when we see CD45 versus side scatter, we see there are scant number of cells in the lymphocyte gate, which is defined by bright CD45 and low side scatter. Very few cells are there in the granulocyte gate, which has very high side scatter, and dim CD45 than lymphocytes, and there is essentially nothing in the monocyte gate. Majority of the cells are in the blast gate, which is defined by dim CD45 and low side scatter. And when we follow through these blasts, they are painted red and they express HLA-DR. They have a partial dim CD34 expression. They are negative for CD117, CD33. They have partial CD38 expression. They are negative for 11B. They're negative for CD13, negative for 64, and CD14. So they're negative for the myeloid markers. The myeloid markers that we have seen are 117, 13 and 33, and monocytic markers 14 and 64, 11B, all of these are negative. So far, it's been positive for HLA-DR, partial 34 and partial 38. And then when we go to the T cell markers, they are negative for 3 and 7, 4 and 8. So then we have the B cell tubes, which have CD19, CD20, and CD10. So here we see that the blasts express bright, homogeneous CD19 and CD10, and they have a partial CD20 expression. And when we go to the cytoplasmic tube, we see that they express CD19, partial cytoplasmic TDT. They express homogeneous CD9, and they are negative for CD22. So the only markers that are positive on these blasts are the B lineage markers, CD19, 10, partial 20, and partial 20. And the immaturity markers that we see are TDT and partial CD34. And for B lineage, HLA-DR can also be considered as immaturity marker. And CD9 is usually positive on BALLs, and that's what we see here. So this is a classic case of B lymphoblastic leukemia. So most labs use CD19, 10, and 20 in their screening tubes, and then when that is positive, they add on the cytoplasmic tube to look for CD22 expression and also to look for additional markers so that they can get a more detailed phenotype, which can be used to analyze later when they evaluate for MRD. And CD22 and CD19 are also therapeutically important because we now have antibodies to them that are used for treatment. For example, we use blinatumomab for CD19, which is an anti-CD19 antibody, which is used in therapy of especially relapsed refractory BALLs and also in MRDs. And we have inotuzumab, which is against the CD22 antigen. So nowadays, even if you do not do CD22, the clinician will call you and ask for the CD22 expression. So please add CD22 upfront when you see a BALL and report that in your report, along with the percentage of CD22 positivity. And some clinical trials also require the information on the percentage of blasts expressing CD20. So they say that they can use rituximab for some cases of relapsed refractory BALLs if more than 20% blasts express CD20. So the percentages are important for CD20 and CD22. It is not very essential for CD19 because they are usually bright and homogeneously positive for B lineage blasts. And you need CD19 along with a bright CD10 to call it BALL. If it is negative for CD10, then you need some other additional markers, like, for example, CD22 or CD79A to call it BALL. 19 is usually bright and homogeneous. If 19 is not very bright or if it is partial, then you need 2 additional markers that are strongly expressed to call it BALL, which could be from CD10, 79A, and CD22. If it is a tissue specimen, PAX5 can also help. Thank you.